Hi, everybody. I am Dr. Prasanna Kumar, endocrinologist from Bengaluru. We will be discussing today about cardiovascular benefit of SGLT2 and DPP4 inhibitor combination as well. As you know, the impact of diabetes on cardiovascular risk as the age advances, both men and women, whether they have previous MI or not, the cardiovascular the risk increases in both men and women with diabetes. It's almost double compared to non-diabetic as such. There are various cardiovascular outcome trials, whether it is DPP4 inhibitor or SGLT2 inhibitors, like SAVOR-TIMI about sexa, examine about elagliptin and about the TICOS, about the sitagliptin, and also about SGLT2 like EMPA-REG outcome, and about the canvas, about canagliflozin, so many other studies, both including the declarative about DAPA as well as credentials. All these studies have shown the cardiovascular outcome trial about the safety of the anti-diabetic drugs regarding the cardiovascular events in some. And the expectation from diabetes management is that approaches aiming at reducing hyperglycemic burden should result in a clear-cut reduction of cardiovascular events in the diabetic population as such. It is not enough, FDA says, that the anti-diabetic drugs should also be cardiovascular safe. Now, when you assess a drug, you look at the assess of the risk of diabetes complication like atherosclerotic vascular disease and heart failure history and stage of CKD and also hypoglycemic risk. When you put a goal setting in a diabetic, you should set HbA1c as a goal, and if hypertension is there, the blood pressure goal and diabetes self-management goal. When it comes to therapeutic treatment plan, lifestyle management, pharmacotherapy of cardiovascular risk and renal risk factors, and referrals to diabetes educator for specific necessities as such. The ADA standard of care 2020 says that SGLT2 with proven cardiovascular benefit is recommended for type 2 diabetics with atherosclerotic cardiovascular disease or indicators of high risk, established kidney disease or heart failure, independent of A1C, and in consideration of patient specific factors. The first line of therapy is always metformin and lifestyle modification. In case there are atherosclerotic cardiovascular disease predominates, heart failure or CKD predominates, then the second line of drugs should be SGLT2 inhibitors. They are the ones should be added. So also if you look at ES guidelines, when A1C is more than 7.5, you should have dual therapy. And after metformin, SGLT2 inhibitors or DPP4 inhibitors are one of the drugs you must choose. And different classes of drugs are listed to be used as dual therapy when A1C is more than 7.5. This is what ES 2019 guidelines are. Suffice it to say that pharmacological approaches to glycemic treatment, sequential addition of oral agents to metformin has been the standard of care. However, there is data to support initial combination therapy for more rapid attainment of glycemic goals are important. Moreover, since the absolute effectiveness of most oral drugs rarely exceed 1%, initial combination therapy should be considered in patients presenting with A1C levels of more than which has to reduce more than 1.5 to 2% as such. Now, there are many studies starting from 2015. We had EMPA-REG outcome study, which demonstrated significant benefits of empagliflozin for CV mortality by 38% and CV events as well as MACE in type 2 diabetes and CV disease. Later on, we had the EMPA heart studies, and now we have the latest EMPEROR trial. It has also been reported that SGLT2 inhibitors promote reverse cardiac remodeling, improve myocardial energetics and filling conditions, reduce left ventricular fall stress and mass, and reduce blood pressure and arterial stiffness. So the latest EMPEROR program 2020 showed that empagliflozin effects on the reduction of prevention of heart failure events in type 2 diabetes patients with established cardiovascular disease that it has been proved. So also if we look at linagliptin trials like Carmelina and Carolina studies has demonstrated CV and renal safety of linagliptin versus placebo or active comparator when added to standard care in patients with type 2 diabetes who are at high risk of vascular complication. Thus, combination of the linagliptin DPP4 inhibitor as well as the SGLT2 inhibitors offers a suitable component in strategy to achieve target HbA1c without hypoglycemia and weight gain in patients with high baseline A1C level together with cardioprotective effects as such. So there is a rationale in using this combination of SGLT2 and DPP4 inhibitor. Pathophysiological causes like omnious octet, glycemic control, greater chance of reaching the target, end organ protection like cardio and renal protection with this combination, complementary action, that is the rise in glucagon is offset by DPP4, which occurs with the SGLT2, and pleiotropic benefits like systolic blood pressure and uric acid body weight reduction with the SGLT2 inhibitors, and better tolerability profile, less hypoglycemia. That's what you see with this combination. So as you see that SGLT2 inhibitor reduce body weight, DPP4 neutral. The SGLT2 inhibitors reduce systolic blood pressure by 4 millimeters, whereas DPP4 is neutral. Uric acid is reduced by SGLT2 inhibitors. Cardiovascular outcomes are reduced, whereas it is neutral in case of DPP4 inhibitors. Mortality, CV, and all-cause mortality is reduced by SGLT2. DPP4 inhibitors. Renal events are reduced with SGLT2, whereas DPP4 are neutral. And microalbumin reduction is much more with DPP4 inhibitors, especially linagliptin, compared to the other drug acid. So taking these things, the glycemic efficacy of empagliflozin and linagliptin shows when both of them are used in dose of EMPA 25 Lina 5, it has got maximum benefit of HbA1c reduction as such compared to EMPA 10 25 mg or linagliptin 5 mg. Thus, there is a need for this combination. Even the percentage of patients on A1C target and risk of hypoglycemia with empagliflozin linagliptin is much more. That's why you see EMPA 25 mg Lina 5 milligrams has shown that it is highly efficacious, no increase of hypoglycemia with this combination as such. Again, the pleiotropic benefit of EMPA-LINA combination is significant body weight, systolic blood pressure and diastolic blood pressure reducing. As I said, this combination reduces systolic by about 4 millimeter and diastolic by about 2 millimeter as such. And the risk of albuminuria progression with this combination of EMPA and LINA is quite great compared to the placebo in almost 1 year study as such, which has been published. There is a lower risk of consistent genital infection when you combine DPP4 with SGLT2 because SGLT2 inhibitors have a side effect of increased genital and urinary infection. When the combination of SGLT2 and DPP4 inhibitor are used, then you see there is a consistent decrease in genital and urinary infection as such. Thus, it's a very good combination. So, if we see the total heart failure and cardiovascular death, 3-point MACE, renal outcomes, all of them are much better when you use the SGLT2 inhibitors as such. This is what most of the studies have shown. So renal CV outcome for EMPA-LINA combination also shows both in the EMPA-REG outcome as CARMEL-LINA studies. The heart failure, the incidence also reduces. Risk of progression to albuminuria also reduces. New onset or worsening of nephropathy also reduced in this combination. So thus, to summarize, combination of SGLT2 and DPP4 inhibitor is an attractive treatment option because both of them are complementary pathophysiological pathways addressing multiple metabolic abnormalities, delaying progressive disease course of the disease, greater A1C reduction, and enabling more patients to reach the glycemic goals, less risk of hypoglycemia, and early achievement of glycemic goal with a durable efficacy when you combine SGLT2 with DPP4, and added benefit of potential weight loss, modest reduction in blood pressure, and DPP4 class has shown no increase in MACE, whereas empagliflozin has shown a decreased risk of the primary outcome MACE and outcome of cardiovascular disease, potential of lower the genital tract infection with EMPA-LINA as compared to SGLT2 alone. This is what I wanted to share with you for a short period of time, how in your practice combination of SGLT2 and a DPP4 inhibitors like empagliflozin and linagliptin is a very attractive treatment option, and also scientifically it makes sense for a good control and cardiovascular and renal protection. Thank you for your attention.